Looks like osteoarthritis. Why we need X-ray for osteoarthritis? There are some clear findings like Boucher's node and Heberden lobes is present. Okay, so in osteoarthritis of the hand osteoarthritis, there is Boucher's node, there is Heberden nodes. Okay, this patient has osteoarthritis. This patient has osteoarthritis of the hands, which presents with chronic joint pain that is worse with activity and relieved by rest. That is worse with activity and relieved by rest, which presents with chronic joint pain. Sorry. Examination shows Heberden and Boucher's node. Examination show Heberden and Boucher's node at the distal interphalangeal and proximal interphalangeal joints, respectively, which represents bony enlargement adjacent to the articular cartilage and are pathognomonic of osteoarthritis. Bone, mm, okay, a bony hypertrophy is often also found at the first carpometacarpal joint, base of the thumb. Osteoarthritis, hands OA of the hands is primarily a clinical diagnosis and is often apparent at the time of initial presentation. It may be mm, X-ray may be performed in ambiguous cases and may show decreased joint space, subchondral sclerosis, periarticular osteophytes. Okay. However, imaging is less sensitive than examination finding is usually unnecessary for diagnosis and management. Okay. You have studied from University of Houston, Texas. Okay. Okay. It is seen in here. like in team it has just shown me. Okay. Yes, sir. Hi. Maybe. Looks like. Yes, and pain and stiffness in neck, shoulder, hips. This is not the common presentation of RA. RA comes with a small joint. Okay. Polymyalgia rheumatic characteristics feature age more than 50. ESR and CRP is high, subacute to chronic pain, subacute to age more than 50, subacute to chronic pain in the shoulder hip girdle. There is morning stiffness more than 1 hour, absence of point tenderness or muscle weakness, constitutional symptoms, malaise, weight loss, and elevated ESR, C-reactive protein. Patient physical examination finding PMR. Physical examination finding in PMR are non-specific and frequently normal, although reduced range of motion, limited shoulder abduction may be present. When asked to identify the location of their pain, patient typically indicate soft tissue, not the joint. Overt synovitis, erythema swelling is not common. Low dose glucocorticoid prednisolone 10 to 20 mg daily is the first line treatment of polymyalgia rheumatica. Rapid and thorough relief of the symptoms is expected, and lack of rapid movement mm, improvement should call the diagnosis in question. PMR is usually associated with giant cell arteritis. Symptoms include mm, headache, jaw claudication, vision changes, vision loss, tenderness over the temporal artery, note of which is present in this patient with suspected giant cell arteritis should receive immediate treatment with a high dose glucocorticoid prednisolone 60 to 80 milligram and are generally referred for expedited temporal artery biopsy. Okay. Is it reactive arthritis? Is it related to STD? So unprotected. Okay. Uh, I asked reactive arthritis. I thought initially the shy chicks like Shigella, those reactive arthritis. But there is a clear indication in here like severe 3 to 4 centimeter non-tender pustules. So, so yes, so there is a dermatitis, there is joint pain, looks like disseminated gonococcal infection. Okay, this patient has likely disseminated gonococcal infection, which usually presents with either purulent monoarthritis or which usually present with either purulent monoarthritis or a triad of pustular rash, migratory arthalgia, and tenosynovitis. Although it is unclear why disseminated gonococcal infection causes two distinct systemic syndrome. A minority of the patient with DGI have overlapping manifestation, and there is particularly common when the condition is untreated for long period. When the condition is untreated for long period, as is likely in this patient with with symptoms more than one. Neisseria gonorrhoeae is transmitted by unprotected sexual intercourse. It is connected by unprotected sexual intercourse. It typically causes It typically causes infectious urethritis, discharge, dysuria, but asymptomatic infections are common, particularly in women. Untreated urogenital infection can spread through the blood, leading to DGI in 0.5 to 3% of the cases. Patient with suspected diffuse gonococcal infection who have joint diffusion and require synovial sampling. In contrast to most other forms of bacterial arthritis, diffuse gonococcal infection is marked by synovial fluid leukocyte less than 50,000. In addition, synovial fluid culture is usually negative because Neisseria gonorrhoeae is a fastidious intracellular organism that does not grow well on standard media. As such, DGI is generally diagnosed presumably based on clinical symptom and a positive urogenital nucleic acid amplification test. So treatment is ivermectin and is curative in most of the cases. Next. Patient does not have fever. But is it other
No.
in between these two?
Yes.
Is it compression fracture?
No.
Then osteomyelitis. So I distract you by saying no fever. Usually compression happens in the older age, isn't it? And it happens due to trauma, uh, like he carry a weight, then there is low back pain starts. Like 70, 80 years old men carry a heavy load or carry a box, then he starts pain. That kind of thing is the compression fracture, vertebral compression fracture. And there is a drug history like IV heroin. That's why it is osteomyelitis. I have seen the IV heroin, but I missed. Okay, this patient most likely has vertebral osteomyelitis. Patient with IV drug use, sickle cell anemia. Patient with IV drug use, sickle cell anemia, immunosuppression are at highest risk. The spine is frequent site in those with injection drug use, reflecting hematogenous spread to the highly vascular spine. Staph aureus is the common pathogen, but infectious with gram-negative organism also occur. Many classes of vertebral compression, many classes of vertebral osteomyelitis are chronic, more than 6 weeks, and insidious with minimal non-specific symptoms, often initially attributed to muscular back pain. Many patients have worsening back pain unrelieved by rest. Fever is present less than 50% cases. Fever is present less than 50% cases. Physical examination often show few findings, but focal tenderness to gentle percussion on the spinous process of the involved vertebral number 3, 4 in this patient can be important clue. Paravertebral spasm and reduced spinal range of motion may be seen. A high index suspicion should be maintained. Worsening back pain with localized spine tenderness in a patient with injection drug use. In addition to fever, being an unreliable finding, lymphocytes may be elevated or normal. Elevated platelet count may be present as a marker of inflammation, and ESR is often significantly elevated. MRI is often sensitive diagnostic study, and treatment include IV long-term IV antibiotics with or without surgery. Okay. Okay, it's PhD, posterior hip dislocation, posterior inferior displacement of the femoral head. This patient has a posterior hip dislocation following a high velocity trauma. Posterior hip dislocation, femoral head displaced posteriorly, femoral head displaced posteriorly with respect to the acetabulum, generally occurs in head-on motor vehicle collision in which the knee strikes the dashboard while the hip is flexed and abducted. On examination, leg appears shortened and internally rotated, often with hip flexed, often with hip flexion and adduction. Range of motion is limited and can be very painful. The dislocation itself can leave the leg in a fixed position. In addition, because it runs close to the posterior aspect of the hip joint, as it runs the posterior aspect of the hip joint, the sciatic nerve, which branches the common fibular and tibial nerve, the sciatic nerve, which branches the common fibular and tibial nerve, participate in the innervation of most of the most of the lower leg musculature and is vulnerable to injury. Weakness of knee flexion, sciatic nerve, and ankle dorsiflexion, common fibular nerve, decrease ankle reflex. So weakness of the knee flexion, sciatic nerve, ankle dorsiflexion, common fibular nerve, and decrease ankle reflex, tibial nerve, decrease sensation in the distribution of the nerve can be seen. Other potential complication of the PhD include tear of the labrum, fracture of the femoral head, acetabulum, and arterial injury with avascular necrosis of the femoral head. Hydrochloroquine can cause retinopathy, isn't it? Okay, this patient with a new diagnosis of the SLE, this patient with a new diagnosis of the SLE has limited disease with skin, joint, and mucosal manifestations. Disease activity SLE can be mounted. Disease activity in SLE should be monitored with periodic blood count, inflammatory markers like ESR, complement level, anti-TSD, and antibody titer. Patients should also be screened regularly for lupus nephritis with urine analysis, serum creatinine, and urine proteinuria. The choice of the drug therapy in SLA depends on the degree of organ development. Most patients with active SLA benefit from hydroxychloroquine is safe and well tolerated medication. However, it can cause retinal toxicity on a rare occasion with the potential for irreversible vision loss. This patient is more com- this is the most common after 5 to 7 years of therapy. For this reason, patients treated with hydroxychloroquine should have baseline ophthalmologic evaluation with annual reassessment beginning after 5 years. Okay, yes. Methotrexate is folate antagonist, folate antimetabolites. Methotrexate can side effect is hepatotoxicity, stomatitis, cytopenia, HSC. Leflunomide, pyrimidine synthesis inhibitor, leflunomide, hepatotoxicity and cytopenia. Hydroxychloroquine can cause retinopathy, TNF, and IL-1 suppressor. Sulfasalazine can cause hepatotoxicity, stomatitis, hemolytic anemia, TNF, and IL-1 suppressor. And TNF alpha inhibitor. TNF alpha inhibitor, infection, demyelination, congestive heart failure, and malignancy. Okay, yes, okay. So this patient experienced an unwitnessed fall resulting in left femoral neck fracture. Most hip fracture most hip fracture require surgical fixation. The specific intervention that is total hip arthroplasty intermedullary knee and and sorry, depends on the exact location and detail of the individual case. In medically stable patient, surgical repair should be performed as soon as feasible, typically within 24 hours to relieve pain, minimize complication, and reduce length to hospital delay. Reduce length of hospital delay. However, in patients with unstable medical condition, such as this one, surgery may be temporarily mm, so- unstable condition, as in this one, surgery may be temporarily delayed to perform more extensive preoperative evaluation. Okay, in patient with unstable medical condition, such as this one, surgery may be temporarily delayed to perform more extensive preoperative evaluation. The patient's inability to recall the circumstances on his fall and his uncertainty about whether he lost consciousness, whether he lost consciousness and whether he lost consciousness raise suspicion for a syncopal episode. Syncopal episode. His tachycardia and palpitation may be due to arrhythmia. Decreased breath sound on the right side could be due to pleural effusion, cough, dyspnea, and left basilar crackles. Left basilar crackles also suggest pulmonary edema and pneumonia. The patient should therefore be evaluated for ECG, cardiac marker, and chest X-ray. ECG, cardiac marker, and chest X-ray to determine the etiology of his fall and assess the preoperative risk prior to surgical correction of this fracture. Acute decompensated heart failure and unstable arrhythmia. Acute decompensated heart failure and unstable arrhythmia consider high risk factor warranting further workup. Once this medical condition is diagnosed and optimized, diuresis or heart failure, he may be cleared for surgical intervention. A delay surgery more than 72 hours should be avoided when possible. These may be possible. Okay, okay. Can I take a 5 minute break? I'm feeling drowsy. Okay, I'm coming. Is it charcoal? Okay. Okay. This patient has foot and ankle deformities. This patient has foot and ankle deformities. X-ray finding include neuropathic charcot arthropathy. Neuropathic charcot arthropathy, which occurs most commonly in patient with diabetes mellitus. Patient with diabetes mellitus, particularly with peripheral neuropathy, particularly with peripheral neuropathy. Neuropathic arthropathy involves repeated bone and tissue trauma and caused by impaired sensation and joint proprioception that prevent the patient from adjusting weight bearing to avoid mechanically induced wear and tear. Neuropathic arthropathy can occur in either two stages. Neuropathic arthropathy can present in either two stages. Acute is characterized by inflammatory erythema, warmth, edema of the foot for 1 to 2 days after minor trauma. X-ray at this stage usually show X-ray at this stage usually show only soft tissue swelling without bone involvement. Chronic chronic characterized by bone deformities noted on X-ray that typically includes osseous fragmentation, new bone formation, osseous fragmentation, new bone formation, subluxation or dislocation predominantly in the predominantly in the mid and hind foot. Other common signs are loss of the metatarsal head, pencil pointing, loss of the metatarsal head, pencil pointing with osteopenia and phalangeal osteolysis. These changes often lead to neuropathic ulcer, collapse, rocker bottom fit, and callus formation. Okay, yes, flowchart. Okay, impaired sensation and joint proprioception. Impaired sensation and joint proprioception. There is repetitive bone and soft tissue trauma, acute inflammation and vascular changes, bone resorption, which will increase osteoclast stimulation, bone ligament bone and ligament destruction, stress fracture, subluxation, and arch collapse, abnormal weight bearing, foot ulcer, cellulitis, osteomyelitis, and amputation. Okay, okay. Age 0 to 2, Genuverum. Then at around age 2, there is neutral, then Genuvalgum. And finally, at age 7 or more than 7, it is neutral. This is the lower extremity alignment. So genu verum, that means bow legs, is a condition in which the legs angulate away from the midline. The legs angulate away from midline, causing a gap between the knees, This child likely has physiologic genu verum, a normal bowing that appears from birth to age 2 due to expected lower extremity alignment changes. This angulation is often noticeable. This angulation is often noticeable as the child begins to walk around age 12 to 15 months. Characteristics of physiologic genu verum include symmetric bowing, normal stature, no leg length discrepancy, no lateral thrust or when walking. Diagnosis is clinical, management is reassurance and observation, and as physiologic genoverum resolves age 2. Okay, Thinking what what
something, but it's like
is it like, she she in addition walking like she's transitioned to plant-based diet. Oh, is this a clue? Thinking. Bilateral ankle, knee, elbow, wrist have mild swelling and tenderness. Mild swelling and tenderness, 14 year. Is it JIA? So in JIA, naproxen is the treatment. Yes, it's the kids rheumatoid arthritis, age less than 16. And bilateral ankle, knee, elbow, wrist. So it is polyarticular GI. Yes, okay. It's juvenile idiopathic arthritis, juvenile idiopathic arthritis, a chronic autoinflammatory condition, is the most common cause of arthritis in children. Polyarticular GIA. Polyarticular GIA, as seen in this patient, involves five or more than five joints within 6 months of disease. Within 6 months of disease onset, and is most commonly diagnosed in toddler and adolescent girl. Bimodal distribution. Patient typically have joint pain and stiffness that is worse in the morning and improves over the course of the day. Symmetric involvement of the elbow, wrist, knee, and ankle, as in this patient, is common. In addition, swelling of the small joints of the hands and the feet may be seen, particularly in older children. Fever and other systemic symptoms like rash do not occur with polyarticular GI. Diagnosis is clinical, and first line treatment is NSAIDs, naproxen. Disease modifying anti-rheumatic drugs such as methotrexate are often required. Okay, yes. Systemic GI frequency is 10%, age of onset less than 18. There are some clinical criteria like more than arthritis one or more than one joint for 6 weeks, quotidian fever for 2 weeks, evanescent rash, hypotosplenomegaly, and lymphadenopathy. Evanescent means maybe salmon pink color of rash, and
mhm.
quotidian fever like fever has temperature is around 39 degrees Celsius or 101 or 2 degree Fahrenheit, and it has two peaks. Like, and in between the peak, the rash actually appears, and it becomes normal after the fever subsides. So that's the quotidian fever, and it persists for more than 2 weeks. Okay, polyarticular and oligoarticular is like joint counting, like polyarticular 40% frequency and oligoarticular 50%. Polyarticular means five or more than five joints and associated with uveitis, and oligoarticular is again associated with uveitis, and it is less than five joints. And female has more propensity of happening this poly and oligoarticular than the men. Okay. Is he has rheumatoid arthritis? So, CCP is for rheumatoid arthritis. Sometimes rheumatoid factor may be negative, but all the clinical feature looks like RA. Okay. This patient, this patient has, this patient has prolonged morning stiffness and chronic symmetric polyarthritis with synovitis, bogginess on examination, predominantly involving the proximal interphalangeal and metacarpophalangeal joints in association with elevated ASR and systemic symptoms in association with elevated ASR and systemic symptoms, fatigue, weight loss. These presentations suggest rheumatoid arthritis. RA is diagnosed primarily based on clinical findings. However, serology can help clarify the diagnosis. Rheumatoid factor RF antibody directed at the FC portion of the IgG and has moderate sensitivity, but specificity is poor. It may be positive in a variety of the disorder. Sjogren's syndrome, mixed cryoglobulinemia, viral hepatitis in healthy individuals, and CCP, cyclic citrulline peptide antibody, anti-CCP, have similar sensitivity to RF but higher specificity, more than 90% for RA. In patient whom RA is suspected but who have negative rheumatic factor test result, anti-CCP testing should be obtained. Seronegative RA negative assay for rheumatic factor and anti-CCP often carries a better prognosis. However, many patients with initially seronegative disease will develop often positive markers later in their course. Okay.
Oh, do you know try to get people for evaluation of that meaning? Not.
Is it GIA? There are some criteria like arthritis more than one joint. There is left knee pain. So arthritis one or more than one joint plus there is rash, erythematous macular rash. No hepatosplenomegaly. Mm, okay, two criteria met, and there is leukocytosis. Okay, So this patient has chronic arthritis, daily fever, and a rash, which are consistent with systemic GI, which are consistent with systemic GIA. Systemic GIA is an arthritic autoinflammatory disease of the childhood. The condition is characterized by 2 or more than 2 weeks of fever, quotidian fever, fixed arthritis lasting 6 or more than 6 weeks, and a pink macular rash that worsens during fever. Pink macular rash that worsens during fever. With other rheumatological disorders, the joint pain, as with other rheumatological disorder, the joint pain and stiffness are classically worse in the morning and improve throughout the day. Other clinical findings include lymphadenopathy, hepatosplenomegaly. The classic presentation, okay, the clinical presentation of systemic GIA from polyarticular or auricular GIA, neither of which is associated with fever or rash. Which is associated with fever or rash. Characteristics findings of systemic GIA include leukocytosis, thrombocytosis are markedly elevated, lymphocytosis, thrombocytosis are markedly elevated, inflammatory marker ESR, CRP, as well as anemia from chronic inflammation and iron deficiency. Treatment include anti-inflammatory therapy such as NSAIDs and biologic agents. NSAIDs and biologic agents. Okay,
Let's see, okay.
yes. Osteomyelitis is a hematogenous bacterial infection of the bone, not the joint space. Septic arthritis, a bacterial joint infection, is an orthopedic emergency that presents acutely with persistent fever, inability to bear weight, and progressive joint pain and swelling. These patients' intermittent fever, ability to bear weight, and chronic time course without symptom progression make infection unlikely. And transient synovitis presents in young children with acute pain and restricted range of motion of the hip joint following viral illness. Fever is typically absent and a low grade rash is uncommon, and inflammatory markers are normal or only mildly elevated. Okay,
If the boy comes to the office with worse and event,
Is it plantar fasciitis? Okay, then it is calcaneal apophysitis. Okay, I got wrong. This patient has tarsal tunnel syndrome. Tarsal tunnel syndrome for posterior tibial nerve. Posterior tibial nerve compression as it passes under the flexor retinaculum. Posterior tibial nerve as it passes under the flexor retinaculum in the medial knee. Tarsal tunnel syndrome is common in runners due to overuse. Due to overuse, tendinopathy, tenosynovitis, repetitive microtrauma, poor biomechanics. Risk is increased with excessive tensile stress on the nerve. Risk is increased with excessive tensile stress on the nerve, pes planus, and other lower extremity deformities, fracture, calcaneus, medial malleolus, and post-traumatic scar tissue. Tarsal tunnel syndrome presents with burning neuropathic numbness and muscle cramps in the nerve distribution, primarily in the posterior medial ankle, heel, sole, and toes. The pain worsened by weight bearing and relieved by rest, and is reproduced by percussing the nerve in the posterior medial malleolar area, Tinelson. The pain reproduced the pain worsened by weight bearing and relieved by rest, and is reproduced by percussing the nerve posterior medial malleolar area, Tinelson, or by dorsiflexion, eversion, and plantar flexion, inversion of the ankle, which stress and compress the nerve. So dorsiflexion, plantar flexion, dorsiflexion, eversion, dorsiflexion, eversion, and plantar flexion, inversion of the ankle, which stress and compress the nerve. Okay, the provisional diagnosis can be made based on clinical features, although findings are often ambiguous. X-ray and MRI help to rule out the structural deformity. Nerve conduction studies sometimes confirm the physiologic defect at the tarsal tunnel, similar to carpal tunnel. Initial treatment include NSAIDs, shoe orthotics, and activity modification. Corticosteroid injection can be useful, and diagnostic refractory cases may require surgical release. Oh, wait 1 minute, I'm calling you. Hello, can you hear me? Okay, I have reading the explanation. Should I read the box? Okay, okay. Mm, the tibial anterior muscle is located in the anterior leg segment. Anterior leg compartment is responsible for ankle dorsiflexion, and therefore tendinopathy presence with anterior ankle. Tendinopathy presence with anterior ankle pain worsened by increased tendon stress during muscle contraction, ankle dorsiflexion against resistance. Okay.
slide.
Yes. Okay. Polymyositis. Polymyositis is an inflammatory muscle disease. Polymyositis is an inflammatory muscle disease that presents with slowly progressive proximal weakness and lower extremities. Proximal arm weakness usually follows, leading to difficulty working with arms overhead. Patients may develop dysphagia due to involvement of the striated muscle of the upper pharynx. Mild mild pain or tenderness can develop due to inflammation. However, significant pain or a lack of weakness should prompt consideration or other diagnosis. Polymyositis is similar to dermatomyositis but without skin finding. Muscle enzyme creatine kinase are invariably elevated. Creatine kinase are invariably elevated, and autoantibodies, anti-nuclear antibody, anti-Jo1 antibody are present in most cases. A muscle biopsy is most definitive diagnostic test and show a mononuclear infiltrate surrounding the necrotic and regenerating muscle fibers. Yes. Okay. Ewing sarcoma is the second common cause of Ewing sarcoma is the second common cause of malignant tumor of the bone of the childhood. after osteosarcoma and wide typically affects with white adolescent boy. The tumor usually occurs in the pelvis or diaphysis of the long bone and often metastases early to the lungs, bones, and bone marrow. Clinical presentation includes subacute or chronic localized pain and swelling. Pain is often worse at night and with activity and progress rapidly. Local erythema and warmth are common. Symmetric findings and systemic findings: fever, weight loss, leukocytosis. Fever, weight loss, leukocytosis, elevated inflammatory markers may occur, particularly with metastatic disease. Imaging of Ewing sarcoma classically reveal lamellated periosteal reaction in which central poorly defined lytic lesion is surrounded by a concentric layer of newborn onion skinning. A moth-eaten or mottled appearance can occur with extension into the tissue. Codman's triangle is a non-specific radiographic finding that presents with displacement of elevation of the periosteum by underlying tumor and can also be seen in osteosarcoma. Treatment includes chemotherapy as well as surgical resection or radiation. Yes, unicameral bone cyst occur in young children. Yeah, can occur in children and young adults, are typically located in the proximal femur or humerus. A pathologic fracture is the most common presentation. X-ray reveals cystic X-ray reveals cystic lesion and with a well-defined margin. Cystic lesion and a well-defined margin. So yes, okay. Like moth-eaten appearance or lamellated appearance is Ewing sarcoma. Also in fibrosarcoma or ragged moth-eaten margin. But in this stem, like it is in the diaphysis, a distal femur and moth-eaten. Uh, these two goes for Ewing sarcoma. Osteosarcoma is in the metaphysis, not in the diaphysis. And osteosarcoma has there are some other feature like Codman's triangle, sun ray appearance. Okay. Ewing sarcoma is the second common pediatric bone malignancy after osteosarcoma. Peak incidence is 10 to 15. Chronic localized pain and swelling with or without soft tissue mass, involves long bone diaphysis, pelvis, axial skeleton, with or without systemic findings like fever, leukocytosis, with increased inflammatory markers. Early metastasis, common lung or bone. X-ray shows central lytic lesion with a moth-eaten appearance, lamellated periosteal reaction. Onion skinning. Biopsy shows small, uniform, round, blue cell. I think that she has RA, Felty syndrome. It is Felty syndrome. Because splenomegaly is present. In Felty syndrome, there is splenomegaly, and she has small joints of the hands and feet are swollen and deformed. Deformed, RA is a deforming disease, but SLE or other is not deforming disease. It is not like, though age is more than like 75, it is not multiple myeloma because the crab does not uh, match thin here. Okay, it's Felty syndrome. Okay, this patient with swollen, this patient with swollen deformed hand joints, this patient with swollen deformed hand joints and elevated ESR rates likely has untreated inflammatory polyarthritis. The presence of concurrent neutropenia and splenomegaly raise strong suspicion for Felty syndrome, an uncommon but serious complication of long-standing erosive rheumatoid arthritis. Felty syndrome is marked by formation of autoantibody against uh, neutrophil components and granulocyte colony stimulating factor, leading to neutropenia, absolute neutrophil count less than 2000, and increased risk for recurrent bacterial infection, particularly of the skin and the sinus. Neutrophil coated with antibiotics, neutrophil coated with antibodies are also trapped in the spleen, which usually results in splenomegaly. Most patients have extraarticular manifestations of the RA, such as lymphadenopathy, rheumatoid nodule, and/or necrotizing skin infection. The diagnosis is based on clinical features and is supported by the presence of high titer rheumatoid factor, anti-citrullinated peptide antibodies. Most patients are also HLA-DR positive. Other causes of neutropenia should be ruled out with bone marrow biopsy and peripheral smear prior establishing the diagnosis. Symptoms generally improve with treatment of the underlying RA. Okay, okay, it's carpal tunnel. So carpal tunnel is bounded by the carpal bones and the transverse carpal ligament. It contains the median nerve. It contains the median nerve along with tendons, along with tendons of the flexor, digitorum profundus and superficialis and flexor pollicis longus. Compression of the nerve causes carpal tunnel syndrome, which is characterized by pain and paresthesia that may involve all or part of the 3.5 digits. Symptoms are often Symptoms are often intermittent and worse at night and may be provoked by repetitive or forceful hand and wrist use, as in this patient who is a carpenter, and patient may report relief from shaking hand. The diagnosis of the carpal tunnel syndrome is usually made clinical diagnosis. The diagnosis of the carpal tunnel syndrome is made on clinical grounds. Provocative maneuvers, Fallon and Tinel tests often reproduce the symptoms but have limited sensitivity and specificity. If examination findings are inconclusive, the diagnosis can be confirmed with nerve conduction study which have high sensitivity and specificity for CTs. Typical findings include slowed conduction velocities in the median nerve across the wrist. Imaging is not routinely indicated, although ultrasound may show swelling of the median nerve.
65.
I think that like a bone scintigraphy finding is the important clue. Looks like Paget's disease. So wait, Paget's disease has two like hearing loss can happen and high output cardiac failure can happen. Osteosarcoma can happen as a complication. Okay. Apart from radio tracer finding, they haven't give anything like isolated ALP. Okay. This patient with chronic Skeletal pain has a Paget's disease of the bone, a common disorder in older adults. Paget's disease of the bone is characterized by abnormal osteoclast activity that leads to increased bone turnover and disordered bone growth. Disordered bone remodeling evaluation often shows an elevated serum ALP level reflecting newborn formation often with thickening of the cortical and trabecular bone and either osteolytic and mixed lytic sclerotic lesion visible on X-ray. Bone turnover in Pagetic lesion causes increased radiotracer uptake on skull scintigraphy, often with a multifocal pattern. Patients with Paget's disease of the bone can develop complication due to focal enlargement, weakness, or fracture bone. Bowing of the long bone and bone pain and arthritis in adjacent joints are common. Vertebral lesions can cause radiculopathy or spinal stenosis. Involvement of the cranial bone as indicated by increased radiotracer uptake in this patient may cause frontal bruising, increased head size, headache, cranial nerve palsy, hearing loss may occur due to enlargement of the temporal bone and encroachment of the cochlea. Okay, yes. Multiple myeloma can present with Multiple myeloma can present with bone pain and can cause acute and chronic kidney injury. However, patients typically have systemic symptom, weight loss, fatigue. Also, X-ray in multiple myeloma reveals multiple lytic lesion, radiotracer uptake, which reflects metabolic activity of the bone, and new bone formation is scant. This patient's bony thickening and multifocal radiotracer uptake are more consistent with Paget's disease of the bone. Pulmonary metastasis can be seen in variety of the malignancies, most notably colorectal, breast, gastric, bladder cancer, as well as melanoma. Although lytic phase Pagetic lesion may resemble malignancy, cortical thickening and accentuated trabecular diagnostic for Paget's disease of bone. Hyperparathyroidism can present with bone pain, often in association with hypercalcemic manifestation, constipation, renal stone. X-ray reveals cortical thinning and not thickening. X-ray reveals cortical thickening, not thickening. And option E, long-term complication of Paget's disease of the bone include malignant transformation leading to osteosarcoma. In contrast, rhabdomyosarcoma is a rare and usually seen in children. It is not associated with Paget's disease and in most cases are sporadic. Look at the femur again. Yes. This patient has slip capital femoral epiphysis, which is characterized by displacement of the proximal femur. Displacement of the proximal femur related to femoral head due to weakening of the femoral growth plate physis. It is commonly seen in obese adolescent 10 to 14, age 10 to 14, because thyroid hormone promotes ossification of the growth plate. Patients with hypothyroidism are also increased risk. Children with endocrinopathies often have slip capital femoral epiphysis at an earlier age, less than 10, and are more likely to develop bilateral disease. Scaphy typically presents with insidious onset of hip, thigh, or knee pain that leads to limping. Minor trauma as in this patient can sometimes exacerbate the pain and prompt the patient to seek medical attention. Examination shows limited internal rotation of the hip, and the thigh externally rotates during passive hip flexion. A posteriorly displaced femoral head on frog leg, lateral hip radiograph is diagnostic. Blue outline. Patient should be prescribed a non-weight bearing status and may require bed rest. If scaphy is bilateral, definitive treatment is prompt surgical screw fixation to stabilize the physis and prevent further slippage. Close reduction is not typically recommended because it can cause damage to the tenous blood supply of the femoral head and lead to avascular necrosis and uncommon but serious complication of scaphy. Okay. Is it greater trochanteric pain syndrome GTPS? Okay. This patient has greater trochanteric pain syndrome. Greater trochanteric pain syndrome is an overuse syndrome involving the tendons of the gluteus medius and minimus where they run. over the greater trochanter. Greater trochanteric pain syndrome is often termed as trochanteric bursitis. Although the bursa although the bursa are not the source of pain in most patients, greater trochanteric pain syndrome typically presents with chronic lateral hip pain, worsened with repetitive hip flexion, climbing stairs, walking uphill, or lying on the affected side. The greater trochanteric pain syndrome primarily uh, primarily on clinical finding. Physical examination show local tenderness over greater trochanter during flexion. Hip range of motion Hip range of motion is normal, although abduction may aggravate the pain. X-ray commonly performed to rule out the concurrent hip joint disorder. Ultrasound may show chronic degeneration and tendinosis of the affected joint. Initial treatment of GTPS is local hit activity modification and NSAIDs. Other oral NSAID ibuprofen are typically used, although topical NSAID diclofenac are very effective. Physical therapy is often helpful. Uh, Physical therapy is often helpful as well. Patients with persistent symptoms despite operative therapy often benefit from local corticosteroid injection, which is generally safe and provides rapid pain relief. Okay,